Welcome back to Tea with the Experts and Dr. Leah Merle. This is season 2 of the What Is series. I'm Dr. Leah Merle, counselor educator, trauma-informed coach, and lifelong advocate for compassion, curiosity, and courage in how we live, work, and connect with others. This season, we're taking our conversations even deeper, exploring how science, story, and souls come together in the human experience, from what is healing in a neurodivergent world to what is the link between temperament and sleep. We'll also be diving into what is burnout recovery, what is ethical AI and mental health, what is collective healing, because healing, after all, is never one-dimensional. What is trauma-informed leadership, what is culturally competent and responsive care. Each episode uncovers the human side of helping, where empathy meets evidence. My goal, as always, is to create a space for nuance, honest dialogue, and kind conversations that you can sit with on your own, individually, or with others over a cup of tea, whether you're a clinician, a parent, a coach, or simply somebody on a journey of growth. You'll find insight, empathy, and perhaps a little inspiration in each episode. So settle in, pour yourself something warm, and join me for season 2 of Tea with the Experts and Dr. Leah Merle, where we keep asking the questions that matter most. Bye for now. Welcome back to Tea with the Experts and Dr. Leah Merle. This is season 2 of the What Is series. And today we're going to dive deep into a term that you might have seen all over social media. Maybe you haven't, but let's have a chance to really unpack AuDHD. That's the overlap of Autism Spectrum Disorder and Attention Deficit Hyperactivity Disorder, or ADHD. So for many adults, especially those who are marginalized or socialized to caretake others first, discovering that they are AuDHD can really feel like both a revelation and a reckoning. So how did everybody miss this, including me? And so to help beyond the memes, move beyond the memes, hot takes and superpower cliches, I'm joined by Dr. Tom Nicholson. Tom is an assistant professor of mental health nursing at Northumbria University. He is a keynote speaker, a trainer, a neurodiversity specialist who's delivered talks and training to over hundreds of thousands of people. His work focuses on turning neurodiversity awareness into real structural change in workplaces, education settings, healthcare, so that systems work for neurodivergent minds, not against them. Tom's PhD research explored the lived experiences of parents whose children are going through ADHD assessments, following wait lists through diagnosis to life after the label. He's also known for his talks on the science of AuDHD, where he challenges traditional medical views of autism and ADHD as totally separate, and the way that social media sometimes flattens neurodivergence into a simple, quirky superpower story. So in this conversation, we're going to explore what AuDHD actually is, why so many people are being identified later in life, how burnout, masking, and misdiagnosis show up, and what truly supportive, trauma-informed, and neuro-inclusive care can look like. So put the kettle on, settle in, and join us as we ask, what is AuDHD? With Dr. Tom Nicholson. Hi, Dr. Tom. Thank you so much for being on the podcast today. Welcome.
Thank you very much, Leah, and hello everyone who's listening at home or in the car or in the bath or wherever you are. Hopefully it should be a bit interesting. I think it will be, but hopefully we'll learn something throughout the journey.
Yeah, I hope so. I'm really excited about this conversation, Dr. Tom. So thanks again for being here. But I think just really starting with that question is, what is AuDHD? Let's start there for our listeners.
So this is both a simple and a difficult question. to answer. And I think one of the reasons why is that AuDHD has it's been a massive rise in the label of AuDHD being used predominantly in the social media space. But in the most simplistic terms, AuDHD is the combination or the co-occurrence, or a medical word would be the comorbidity of an autism diagnosis and an ADHD diagnosis. So you have both diagnosed and met the threshold for an ADHD diagnosis and an autism diagnosis at the same time. Now, the reason why it's a bit of a complicated question to really answer is that there's a big discussion at the moment about whether or not AuDHD is its own thing. Is it actually its own diagnostic label and should be diagnosed as a specific separate label? Or is it just a combination of ADHD and autism? And I'm sure we'll talk a bit more about this, but I think the honest answer, according to the research and according to the best available evidence that we have right now, is we don't know. And the social media space, I think, is talking about it as a done deal. It's talking about it as if it's absolutely its own specific thing. Whereas, of course, there is often so much complexity when we're talking about diagnostic labels, when we talk about how labels change over time, and how the social media discussion can simplify some of the complexities of what makes something evidence-based enough to be a new label or a new diagnostic label.
Yeah, I mean, that is so interesting, this combination piece, and it's almost like when you look at social media, you see which came first, the chicken or the egg.
Yeah.
I mean, it's that piece. I mean, what do you say to people who are in your circle about ADHD? I mean, is it one or the other? I know it's complicated.
It's I personally have my own opinions on this. So I use the term AuDHD to describe myself. I say I was diagnosed with ADHD when I was 5 years old. I recognize that I was autistic at 29. So I am very much that AuDHD presentation, and I use AuDHD as a shorthand to communicate it's ADHD and autism together.
Mm.
Now, I think the complication becomes professionally, medically, research based. I don't believe there's enough evidence just yet to say that it's its own specific, unique thing. So that's not to say that ADHD doesn't exist, because it absolutely does, and I use that language for myself. It's that if we were to use the term ADHD and create this new label that is the intersection of ADHD and autism,
Mm.
well, that brings up another complicated point. What about if it's autism and dyslexia? Do we need a new label for that? What about if it's ADHD and OCD, ADHD and dyscalculia or dyspraxia? And so why is it only ADHD and autism that gets its own specific new label? So
Right.
I think although it's really helpful to have a term that helps people to self-identify and understand their unique sort of mix and mismatch of neurodivergent experiences. I do think we have to be careful with pushing for it to be a new medically classified label, because the question then becomes again, what about all these other co-occurring diagnoses? We know that DCD, developmental coordination disorder, previously dyspraxia, is about 35-40% of ADHDs are dyspraxic.
Yeah.
We would just use them as two separate labels. And might end up getting into labeling theory, and so there are major criticisms of how psychiatry labels things and how labels are used. And for me personally, diagnostic labels do two things. They're as helpful as they're helpful in that they help people to understand their own experiences. They help people to understand what's going on for them. And they also, that's what they do on a personal level, but in a medical perspective, because these are medical labels, they help to identify treatment pathways, the development of pathways and services. And what we've seen historically is when you have lots of unique specialist labels or diagnoses, sometimes that can lead to inconsistencies and inequality in service provision. So that means, for instance, we take autism as an example, the diagnostic label now being autism spectrum disorder or autism spectrum condition, depending on the healthcare providers. But historically, we had Asperger's, core autism, high functioning autism. There was lots and lots of different labels. which was really helpful on an individual level for some people, who could describe themselves as I have Asperger's or I am Aspie as a term that's kind of gone in and out of vogue over time. But that same person might not be able to get provision if the provision and the services are only available for people with an autism diagnosis. So if we have an AuDHD diagnosis, do we now need AuDHD services? AuDHD specific services? We've barely got ADHD and autism services working together at this point. So I think it's more nuanced and more complicated. It's especially pragmatically when you kind of pull behind the curtain of how labels interact with services and evidence.
Mhm.
But yes, I personally use AuDHD as a term, but not as a specific diagnosis.
With that diagnostic criteria, which as you're sharing, that's what the field uses to be able to gain access to services. So that's the difficult ground, right? Isn't it? I mean, in the work that I do, I explain it when I'm teaching as a spectrum, right? Like it's a neurodivergence is more of an umbrella term, and we have a lot of different identifications kind of underneath that, and some of them overlap. A lot of them overlap.
Yeah.
And it's not one or the other, it is sometimes a comorbid presentation.
And I think you're absolutely right. Not only do essentially all of them overlap, and it very seldom do you have someone really who only fulfills the criteria of one condition, one neurodevelopmental condition, and no evidence of any other condition. Of course, they're very overlapping, which is one of the problems with our current system of diagnoses not capturing that.
Yeah.
But also, we've got a significantly increased likelihood of our other mental health and psychiatry diagnoses, anxiety, depression, OCD, compulsive disorders. And so when you have these high complexities, I
Yeah.
think one of the concerns of mine when with working with, I've worked with thousands of people, I've worked with lots of people who have also worked with hundreds, if not thousands of people, is that sometimes people can get really attached to that singular label. I got attached to my own singular label. I saw myself as ADHD and only ADHD for 20 years
Wow.
because I was like, well, I have ADHD. So all these other different odd traits or idiosyncrasies that I have, that's just part of my ADHD. It was only when I was 29 that I recognized, oh, I'm actually autistic. I also fulfilled the criteria for OCD as well. And had I have been just fully attached to just that ADHD label, I might never have been able to get the support and treatment for my OCD. And I might have not done the interventions and adaptations in my life and environment for my more autistic traits. And obviously adding trauma to that as well. And it's trying to work out, what in your experience, what's because of the trauma typically of being a neurodivergent person in a world that doesn't accept and acknowledge you and is unjust and unfair. What's the trauma which might be treatable and where support could really improve things? And what's the autism or ADHD or AuDHD traits, which maybe are a bit more static and a bit less controllable or changeable? And I think, yeah, when we focus in on one label and we focus in on one identity, we can miss some of that nuance,
Um,
which can be both, which can be quite unhelpful. Because people are, especially neurodivergent people, are quite complex. It's
yeah.
very seldom one label, one diagnostic experience, one aspect of that journey.
That's so, so true. And I think sometimes, a lot of the time in our society, there's this either or mentality rather than both and.
Yeah.
So we've definitely in our field we're kind of struggling with it's not black and white. It doesn't work like that. It's really like you said, complex, very
Mhm.
complex.
And the problem, and this is my big sort of like soapbox that I'm standing on at the moment when it is nuance. I talk about the nuance in neurodivergence a lot at the moment because I'm very concerned with the way these things are being framed in predominantly the social media space because you can't express this nuance in a tweet. You can't express this nuance in a TikTok video. You need time and long form content and theoretical discussion to really get the nitty gritty of some of the nuance here of this complexity of again we know that so many neurodivergent people have experienced early life trauma, both familial early life trauma, but also more commonly in educational trauma and institutional sort of educational trauma. So that is going to complicate any picture, any diagnostic picture in different ways. In fact, one of the things I've been thinking a lot about recently, I'm going to go on a mini tangent. We're going on a tangent already because that's what I do. So I've been thinking a lot about RSD, rejection sensitivity dysphoria. And one of the things that I'm seeing in the neurodiversity world is RSD being talked about as if it's exclusive to ADHD. It's a part of ADHD, it's an ADHD thing. And I'm a bit hesitant with that. Of course, RSD is an experience we have. I am incredibly sensitive to rejection. So many people are. I get that I'm in no way saying RSD doesn't exist. I'm not at all.
Yeah.
But the narrative that it's exclusive to ADHD, well, actually, we don't have evidence for that because rejection sensitivity is a big experience for people who've experienced early life trauma, for people with attachment trauma. So rejection sensitivity is not unique to ADHD, but you see that in a number of other diagnoses and other sort of experiences that people have had. And I would hate for those who have experienced early life trauma and don't have ADHD to think that they might have ADHD because they're experiencing that RSD rejection sensitivity, because it's not unique to ADHD. My wife's a trauma therapist. My mum worked in a personality disorder specialist hub for a number of years. This is a big area of discussion in my home life as well as my professional, about how do we parse out what's unique to neurodivergence, what's unique to ADHD and autism, predominantly when we're talking about this discussion, and what's more ubiquitous, what's more common across other difficulties. Attentional difficulties are common in depression. So just because someone has attentional difficulties doesn't mean they have ADHD, because we see that in depression and anxiety. But it's when we get that picture, that more complex spiderweb picture of, well, if they've got this experience and this experience and this and this and this, and it's impairing, and it's been long-standing, and it's severe, then we start using terms like ADHD or autism. And that nuance is, as I say, really hard to get across in a LinkedIn post even.
And I know that there's, you've talked about this in your talks, and also there's a lot of widespread kind of conversation about this regarding the uptick in diagnoses and social media diagnosing, like TikTok diagnosing. And so, can you tell me your thoughts about this, about the uptick of diagnosis and then the influence of social media?
I obviously have a lot of thoughts, and it's a double-edged sword, isn't it? In that there are some incredible positives to the advent of more of neurodiversity being more prevalent on social media. So social media is talking more about neurodivergence, they're talking more about ADHD, more about autism, and then people are connecting in with that. They're looking at this content and thinking, oh, hang on, I connect with this. That sounds a little bit more like me. And they can start normalizing some of the difficulties that they might be having. And that can be really shame reducing. That can be really empowering. That can help people to recognize that they are neurodivergent, and then seek whatever support is appropriate for them, whether that's diagnosis and intervention, or whether that's just, reading the books, listening to the podcast, watching the videos, and changing their lives in ways that are helpful. So that aspect of it is incredibly beneficial, incredibly beneficial. It becomes damaging, and not just damaging to people, but damaging to the movement itself. When we look at some of the research that's showing that the content on social media about ADHD specifically is incredibly misinformed. There was a research article I was reading a few months ago that was saying that about 50% of content in relation to autism and ADHD on TikTok is false. There is not based in any evidence that is in any way related to those two neurotypes or differences. And it's actually, most of it is generic human experience. 25% was was slightly correct, but often hyperbolized, so like over exaggerated. And the last 25% was mostly right, but 90% of content creators don't cite their sources.
Yeah.
So the scientist in me, the academic in me, is terrified of that, because by telling people, saying, if you cuddle a pillow when you go to bed, that might mean you have ADHD. And I'm like, well, no, it doesn't. It's got nothing to do with our ADHD diagnostic criteria, but some ADHDers will cuddle pillows and some won't. And that's more like what they call Barnum effect statements. I'm sure you'll be aware of Barnum effect, but you see them in horoscopes, and where statements are related to everyone, or everyone can connect to some part of those statements, which is really good for social media engagement, but not good for communicating science. So you end up in this situation where the positive is people who are actually neurodivergent, ADHD, autistic, dyslexic, dyspraxic, etc., they access this material. They think, oh, that could be me. Then they seek support, change aspects of their life. Life improves, outcomes improve. That's incredible. And that's such a powerful force for good. The other side is when you have people who aren't neurodivergent in terms of they wouldn't fulfill the criteria for diagnosis. They see generic content. That generic content makes them believe that they might be neurodivergent. And so they go and sit on a waiting list, which is now 4 or 5 years long. In my area, it's 11 years long for an adult assessment, which is appalling. So you're sat on this waiting list for 5, 6 years before you ever see a professional who says, there isn't any evidence here. We don't think it's ADHD or autism. And so you're not going to meet the threshold because you aren't ADHD or autistic. But for 5 years, that person's been building an identity. That's a neurodivergent identity. They've been connecting and associating with that label. And then it's crushing when they don't get even an assessment because they're not accepted for assessment because they don't meet threshold, or they don't get a diagnosis because there's not enough evidence. And so that's also really damaging. And then obviously you've got people on the waiting list who don't need to be on the waiting list, and that's increasing waiting list times and things like that. But I'm less concerned about that element because that is not, we can't put the responsibility on individuals to know what ADHD autism is before they can even get assessed for it. That responsibility should be on the people who are promoting information. It should be on the system and not on people. So I would never blame someone for, I would actually recommend if someone thinks they might be neurodivergent, go through that assessment pathway. The fact that it's taking so long and it's not working for people, that's not your problem. That's a systemic problem, which is one of the things I try to challenge in terms of challenging ineffective social media content and spreading evidence as best I can.
Yeah. I mean, you just touched on those waiting lists, right? And I work with kids, I work with teens, I work with adults, family systems in the work that I do. And, I've come from the States where it is a very different diagnostic system to England, working here and seeing these wait lists firsthand when people do want the support and want the help. But the diagnostic piece or portion is first, right? And then you've got this certain weight. So, what do you say to people, Dr. Tom, about this scenario if they find themselves in this situation?
The first thing I say, I'm sorry. I'm sorry that this isn't good enough. This isn't okay. Your experience, although difficult and unfair and unjust, is unfortunately becoming the average, in that you are not alone in this experience. And that's also not okay. But that's the reality of the current system. I think it's going to change. I think it has to change. But how it changes and what that looks like, no one's quite clear at this point. There's people have some ideas, and there's lots of big projects happening in the background around trying to resolve some of these things. I'm on a few myself, but a couple of things that I would say as well is, so you've got a long wait. You've got a long wait now. I do a talk on the diagnostic journey and what the diagnostic assessment actually looks like. So what to expect. And so if someone knows what that assessment is likely to look like, it can be really helpful to know that early so you can start collecting information. So I'll be thinking about what information can you collect at this point, whether it's uh, reports from school, whether it's reports from any sports teams, like people who run sports teams, whether it's any therapists that you've been working with or any other professionals, just to get reports. And that report isn't an ADHD support report, because I
Yeah.
don't think we should go into these journeys already convinced of knowing exactly what it is, because we can be wrong, because we don't know what we don't know. So it's a report of, what do you see as my child's strengths and difficulties? What does my child seem to struggle with and find difficult that is maybe atypical or different from the other children who you see, but also where are their strengths? What are they good at? So that information collecting early is just a pragmatic, helpful thing to do and can also support the assessment when we get to there. Another thing to think about is what's the hope post-assessment? What is the outcome that you're hoping to get? Because again, the unfortunate reality is that when we think about ADHD diagnosis, for instance, you will get a diagnosis and depending on where you live, you may be offered medication and there may be no other support available. I also don't think that's right. However, that's the system we're in right now. So if you're hoping for everything to change post-diagnosis, that may not happen. So it's thinking before that 4-year assessment, wait, what can you do now? Learn as much as you can. Be what I call an informed parent or an insider parent. So you're listening to the podcast, you're watching the videos, you're reading the books, you're reading the reports, you're reading the research, and you're testing things because interventions and environmental adaptations and changes in your life, they might help one person over here and they might be totally useless for your child and or for your teen or for your parents. So it's like finding and testing different strategies. You can assume whether or not someone's neurodivergent or not, like strategies that are helpful for neurodivergent children and young people are generally helpful for everyone. They're just disproportionately beneficial for neurodivergent people. So if we have, less demands early in the morning with a more structured routine for getting ready, that's helpful for everyone, right? But if we particularly helpful for autistic children, not all, of course, this is very much not a blanket statement, but we see that as being that sort of ritualized, certain, the way we don't have too much doubt or uncertainty in the morning, a clarity of what the morning is going to look like. That's particularly helpful for autistic children or young people who struggle with not knowing what's coming next and struggle with uncertainty. So that's it. But it's also helpful for everyone.
Yeah.
So it's like thinking, what can we do now? Because in my experience, a lot of parents fight and fight and fight for that assessment. They fight and fight and fight for that diagnosis. It's arduous, it's draining, it's exhausting, they're burning out. It's often a horrible experience for the wrong reasons because they're fighting against that system. And they fight till they get that assessment, they get that diagnosis, and they go, yes, but nothing changes.
Now what?
Now what? And they had never thought about this part forward. They'd spent so much of their effort and energy thinking about getting that diagnosis or getting that assessment, that not what it would mean afterwards. And that can be quite impactful. That can be really hard. So I'll be thinking, yeah, practically, pragmatically, what was going to be helpful, whether or not they get a diagnosis or not? What would be helpful if this question never got answered? What can we do anyway? And that, so you can read the books about, supporting neurodivergent children and young people and start trying some interventions. I'm an expert in this field and I'm constantly trying new interventions to see if they work for me. But I've done some things for years and then they've stopped being effective for me. So I've done something else. And that continual learning, but also continually developing and changes because families change as well. That's all part of the journey. Don't get me wrong, it's exhausting. It's tiring. And the research shows that. Anecdotally, the people I've worked with shows that. I'm sure the people you've worked with have talked about how parenting neurodivergent children is hard.
It is.
It's hard. And if you're neurodivergent yourself, it's doubly hard. Well, I'll nuance. Aspects of it are doubly hard. Some aspects of it are much easier. A random example. I'm going to give you a random example. So every Monday, my son and I go to a trampoline park. I'm the only dad there doing backflips. Every single Monday, I adore going to the trampoline park with him. We're bouncing around like crazy. I burn about 600-700 calories every single time I go, and I'm able to just let out all my hyperactivity. He's having a great time. I'm having a great time. In that context, parenting feels easy.
Yeah.
But then I get the calendar from the nursery of all the different events and the times and what you need to remember every single week. That bit's not so easy. That bit's really hard. And that's when I start using my interventions.
Beautifully said. I love that example. And I know me doing my research and coming to hear you speak and just talking with you, you've had your own journey with neurodiversity. And so can you tell me a little bit about your experience and that human aspect for listeners out there?
Absolutely. So as when I introduce myself, I always say I'm a public speaker, professional public speaker. I've trained over 100,000 people. I am an academic. I was a nurse in a ADHD and autism assessment service, but I also am neurodivergent myself. And I think that personal element brings a lot of humanity, or I hope it brings a lot of humanity to my work of actually, I do know what it's like. And my journey was and has been very difficult. I don't mind sharing. I talk about this quite a lot. I was diagnosed at 5 years old, medicated very early. I was on a medication trial for Ritalin in the 90s because I was for younger children. I was really quite impaired. But I also described my sort of family as loving and supportive, but my educational journey is institutionally abusive and traumatic. I had a horrific educational journey. I loved learning, always have loved learning, and I'm quite good at learning, but hated school. Uh, Teachers hated me. For 4 years at school, my seat was at the back of the room, facing the wall, with a blackboard in between me and the normal children. And the teachers would say things like, "Children, imagine that there's an invisible wall between you and Tom, and words cannot get across." So that was my experience for 4 years, and so I was very much on track to be one of those sort of school to prison pipeline children of not achieving anything, not amounting to anything, and was told that at school quite a lot. But I got a lot of support from predominantly my mum, and then some mentors, some educational mentors when I went to high school, which kind of showed me that I could also I was good academically. I never did my homework, and I never did lots of things, and I struggled with loads of other things, but I could perform in an exam. I did very well. And so for me, that negative problem focused narrative kind of dominated a lot of my life. And one of the reasons why I do the work I do, in fact, no, the underlying reason of why I do the work I do is I don't want any child to feel how I felt. Because it was wrong. I should have been protected, and that was morally unjust and unfair and abusive.
Mm.
And society is to blame for that, not just individual teachers. That
Yeah.
was a systems based issue. It was a cultural based issue about what ADHD meant and continues to mean. I also do this both for the children and young people, but for adults who had those experiences as well, to give adults who are neurodivergent, who had these experiences, a new narrative to say that wasn't okay, but it doesn't have to be your narrative moving forward. Your narrative doesn't have to be the the horror of the educational system or whatever ever your experiences were. But ADHD can mean something different now. Autism can mean something different now. And I say that with, again, that nuanced perspective of, I do not use the term superpower as something that I don't use. And sure, I'll talk about why shortly, but we don't have to talk about everything being incredible.
Well,
It's just having a more nuanced, realistic story about what it means for us.
yeah. Oh, I love that, Tom. I really, really love that. And, I connect in some ways with your story because that was me too. That was part of my experience growing up. I was diagnosed with, ADHD, but also with dyscalculia as well. And so, with a math learning disability, I have math anxiety. And literally, even now, trying to do homework with my 9-year-old who also is neurodivergent and has her own struggles with dyslexia, dyscalculia, ADHD, spectrum associated issues. It's really, really activating for me. But I can remember being told to stand in the middle of my class, probably at about 7, maybe 6 or 7, and being embarrassed because I couldn't recite my times tables, and the teacher literally humiliating me and shaming me in front of the class. I remember it now. I mean, I feel it, feel that shame, feel that like redness and that embarrassment that kind of comes up with a story like that. And so I've had multiple experiences like that, which I'm sure you have.
Oh, yeah.
It's part of why I do the work that I do regarding advocacy with neurodivergence and what it means to be neurodivergent, and what support can we do, and how can we talk to parents to help with that that's happening still in the classroom today.
It still happens today. I've worked into over 100 schools, and I still see the normalized discrimination and shaming of
Yeah.
neurodivergent traits in diagnosed children, not just in every children without diagnosis, in diagnosed children, which is discriminatory. It is actually an offense, but we've kind of normalized that in a way where we hide that. And I can really hear what you're saying there about shame. Shame is such a big part for so many neurodivergent people, especially as adults. And it links in with that rejection sensitivity that we were talking about before. That is the rejection sensitivity because we have these ADHD brains, or are we sensitive to rejection because we can recount dozens of experiences of things like that, and
Yeah.
experiences which are deeply shaming, deeply rejecting, deeply abandoning.
Mm. Yeah.
They make us make individuals more sensitive to rejection, to abandonment, to um, those sorts of issues. Add in the ADHD emotional dysregulation, where we're seeing evidence of just general emotional dysregulation across all emotions. So the intensity dial might be up or down, but the rejection sensitivity is actually, I believe, more of a response to the massive amount of rejection so many of us faced,
Yeah.
which again is not ADHD specific, because we see it in we see that same thing in trauma disorders, and people have experienced a lot of early life trauma as well. We see it in CPTSD, attachment difficulties, and the personality disorder diagnoses. Of course, that's another podcast into itself about our discussion of how unhelpful some of those labels can be.
Mm. Wow. Well, thank you for sharing your, part of your personal journey. I feel like, you have a vocabulary, you have experience now, significant experience as an expert in the field with neurodivergence. I have my own language, my own understanding. I have a neurodivergent child, but what about those parents that don't have the language, maybe? And it's not that they don't know how to advocate, but they don't know how to talk the language to be able to traverse the system.
Yeah.
What do you think about that?
Oh, it's a genuine issue, and I think one of the reasons why we see inconsistencies in diagnostic rates depending on the education level of parents.
Mm.
So we see, parents who can pay for private diagnoses, who often have high level of education, so often have more, what they call sort of like cultural resources to draw upon,
Yes.
have a higher likelihood of receiving the diagnosis they expect because they have all these resources to pull upon. For those who maybe don't have those resources, again, so I came from a family where I'm the only person in my entire extended family growing up with a degree. Most of my family, my immediate family, didn't have A levels until I was the first one to get A levels, and then now my younger brothers and sisters do. So I came from a family which didn't have that language either. And one of the things that we can do when we don't have that sort of medical language, when we don't have that organizational systems language, is linking to what I said earlier, to become what I call an insider parent. And an insider parent is someone who understands what the system wants, how the system works, what words are helpful and relevant. Again, because like a parent who might say, "Oh, my kid was having a total meltdown. They were absolutely kicking off." And that language can mean 100 different things as a clinician.
Mm.
So it's trying to almost be as objective as possible with your language. What was going on? What did cause it? And you don't need to have the big fancy words like I'm using some now and throughout this conversation, because as assessors, a competent assessor should be able to pull that out. You should be able to see through the words you're using to get to what's going on underneath. But how we can inform ourselves as parents again is by consuming the right kind of media. And that's the big thing. It links back to that social media discussion, the right kind of media.
Yeah.
I It's about, who are you following? Whose content are you reading about? Are you reading? Is it, if it's all on Instagram and TikTok, like there again, there is some good content there, but it's really hard to be discerning about knowing what is the good stuff and what is the made up rubbish, unhelpful clickbait stuff. And if you're not sure, so it's okay, but go to more trusted sources. Go to, even if you're just looking at the NHS, if you're looking at the National Institute for Care Excellence, nice. If you're looking at ADHD UK, obviously we don't have the ADHD Foundation anymore as they closed a few months ago. So it's, which is endemic of some of the wider issues we're having. But looking at those more charitable organizations, go to networking events, support events, there's lots of lunch and learns and podcasts like this and videos where you have different experts talking about things which can help to build that vocabulary. And I mean vocabulary not just as in words, but that like cognitive vocabulary of, oh, this is how the assessment process works. This is what they are looking for at this point.
Mhm.
This is what they're doing. This is what it is. So the developmental history, for instance, where we're looking at all of the early development and all the milestones. So for a parent who's not sure what's going on, okay, we'll go back and try and find those old books about early milestones. Speak to your parents about your experiences and what things were like for you as a child.
Yeah.
Um, and I do recommend, when you can tolerate it, longer form content.
Mhm.
So videos that are longer than like 8 minutes long are normally able to be a bit more helpful, because that quick fire information is helpful, but it's often generic
Yeah.
because it's really hard to go into a lot of detail on anything in 8 minutes. As we're seeing in this discussion now, like we're meandering around, and so there's so much to talk about. And yeah, this is something that I wish I didn't have to say,
Mm.
but I think it's important that, and it came out in some of my research as well, is predominantly mothers who had to hold down and suppress their own emotions during these journeys, during these assessments, so that they weren't perceived as the histrionic,
Yes.
overly emotional mother. And again, I think there is a reality to that.
Yeah.
There is a bias to that. It's unfair, it's unreasonable, but because these journeys are incredibly distressing, it is really distressing if you think your child has needs which aren't being met, that they need more support. Of course, we want to fight for our kids as much as we can. But as soon as someone's like screaming and shouting in that assessment or in that waiting room or screaming down the phone, I totally get why. I totally understand it, because there is so much pain here. But again, I don't work for any services anymore, but I know that that can negatively impact people's perception of what's going on, and it's not fair. Again, and I think I find myself saying this quite a lot when I'm talking about divergence and journeys and assessments. It's like there's a lot of things that aren't fair here, that aren't reasonable here. But again, it's trying to be as composed, but honest and objective as possible with what's going on. Um, because again, it also might not be ADHD, autism, or AuDHD. Again, I've realized I've not talked specifically too much about AuDHD at this point, but it's all of this ties into the complexity of AuDHD, because all of these elements are relevant to assessment journeys, diagnostic journeys, parent journeys. And I think when it's AuDHD, it just complicates this a little bit further.
It takes it to that next level with complexity and multiple layers. But, I'm really, really pleased as a parent, as an individual who works with a lot of parents, that you've mentioned the classic histrionic mother, because I've seen that a lot with the parents that I work with who have experienced that with their own children. And, advocacy is key. Like I say to parents, you know your child better than anybody. You do. However, you have to stay regulated. You have to regulate yourself. Like talking about superpowers, self regulation is something that you have to have going into these spaces. Can you talk a little bit more about that, Dr. Tom? Because that crosses all of the different diagnoses regarding a parent
There's
guilt.
a lot of diagnoses, a lot of different diagnoses in psychiatry. Um, require sort of difficulties with emotional regulation.
Yeah.
Emotional regulation being our ability to sort of control and manage our own emotions, both in their sort of bouncing from emotion to emotion, how quickly we cycle through emotions, but also how much emotion we feel. So, for instance, if someone's unregulated at a time in a particular situation, you might drop the remote control for the telly off the sofa and be absolutely fuming, furious mad. Now, that's not a regulated response. It's not context appropriate. But of course, there might be lots of other things going on in your life. It's actually been the sort of straw that broke the camel's back. So when we're talking about what emotional regulation is, it's that ability to regulate both cross emotions and also intensity of emotions. Additional to that, you've got a thing called emotional tolerance. And emotional tolerance is our ability to tolerate uncomfortable emotions. So, like, how angry can we feel before it's too much? How, if someone can't tolerate feeling really sad because it's a really unpleasant feeling and that they're not comfortable with feeling sad, they might be more likely to switch over to anger because they can't tolerate feeling sad. So they feel really angry and then they might get really aggressive. And I think that is something that happens at play here because we're so scared and anxious for our children's needs, and it's so scary, and that anxiety is so overwhelming and it's intolerable. Anger is a much more activating, active sort of not in control, but like you feel more in control when you're angry than if you're anxious. So tolerance and regulation are important for everyone. That's important in all mental health care. Again, in therapy, we would talk quite a lot about those two experiences. Now, what complicates this in neurodivergence is we know that for ADHD, we see a lot of emotional dysregulation.
Yeah.
And in autism, we might see different manifestations of emotion. So we might see people being like seemingly less emotive or more internalized emotion, the nonverbal gestures being either over or under exaggerated, things like that. So the communication of that emotion can also be uh, the word I use here is idiosyncratic. What I mean is like unusual or different or atypical. Again, not wrong, just different from the societal norm. So if you have ADHD as a parent, if you're a neurodivergent parent, or you have had other experiences like trauma, like other mental health difficulties that lead to emotional dysregulation, regulating yourself is going to be even harder. And so often support for our children starts with us. And this is I think an uncomfortable truth that there are so many parents who would deeply benefit from their own therapy journey, from their own journey of self-discovery, but they're focused so heavily on their child's that they get lost and missed. And actually, by us being more regulated, having more tools and strategies to manage our own experiences of distress and discomfort, two things happen. If we can manage our own experiences, we can be more of that advocate for our children. We can be more of that sort of unmoving rock of support, but also we model this type of work. We model. If your child sees you having an unpleasant, distressing experience and then using a strategy or technique that you've learned on off a YouTube video or from your therapist and sees you managing that and like feeling better, well, that shows them that that's something helpful and important for them to do. That's social learning theory. It's modeling theory. If we want our children to read books, they should see us reading books. If we want our children to want to play an instrument, they should see us playing an instrument as much as we can, or at least learning an instrument. If you want your children to apologize yourself, so they see what apologies are for, what they look like, how important they are. So we model that behavior. So if we want our children to be regulated, model regulation, model healthy regulation. And if you don't know how to healthily regulate, I get you. I didn't for a long time. It was my therapy journeys that got me to that point. I've had therapy multiple times. I've meditated for 2,000 days straight for a period of time. I exercised regularly. I've tried it all. And so it's doing those things. So it helps you, but all helps you help them, and also teaches them the skills that they're going to need anyway. So all of that's going on. And my last point is that you can't regulate someone else if you're unregulated. So, and I think we see this all the time. A kid, we see this a lot with like I don't believe in things like the terrible twos. I don't believe in, I think toddlers and very young children are expressing their emotions in the healthiest way that they have, because haven't developed the emotional regulation strategy to that point. They haven't developed the emotional intelligence. So toddlers are kicking and screaming in seemingly irrational ways. That's because they are irrational. They neurocognitively don't have the rationality that we do as adults. So if they are very deeply unregulated, and you are too, not only are you not going to teach them how to do it, because you're now not safe, psychologically safe, because you're unregulated, they're unregulated, everyone's just unregulated, and the entire situation's overwhelming for everyone.
Yeah.
And we see that quite a lot. But people start shouting and screaming, and it becomes this cyclical process, which, as I say, can complicate assessments as well.
Mm.
Because if there's lots of this other stuff going on, if there's lots of those sort of like complex and family dynamics, if you have, as an adult, have complex difficulties yourself, we need to know about that as assessors, and we need to have conversations about that, knowing that it will make the assessment slightly more complicated. And so, again, if you know your child's going to be on a waiting list for 6 years, there's 6 years to work on yourself as well. There's 6 years to maybe go down your own diagnostic journey, or your own therapy journey, or your own sort of self-discovery journey, so that when you get to that point in 6 years' time, you can be much more confident in actually, no, we've tried that. We've tried the emotional regulation strategies. We've tried all the helpful stuff already. And there are still these difficulties in attention hyperactivity, impulsivity, emotional dysregulation, rejection sensitivity, social communication difficulties, whatever the traits are. And that is so much more powerful, both from an advocacy perspective, an empowerment perspective, and from a diagnostic perspective. Because I say to people, try and be unarguable.
Mm.
Complicated. I realized this talk for quite a while about
It is.
this, because it's there is so much to get into that.
Yeah. Complicated, but also, I think about that shame element and the stigma attached to what we're talking about here, right? And how it's easy to say, well, get help or go to therapy, but when there are not enough resources available to our parents to be able to get the support that they need and deserve, is that part. But then also when we're saying to somebody, it's time to look in the mirror, that's hard.
Oh god, yeah.
That bit's hard too, and I get it. Like, I say that to parents, like, I totally understand that this is a hard process. But if you want to help your child, you have to start with you first. You have to start with.
Yeah. And that's the term I used very early on in that piece there, was an uncomfortable truth, because it's deeply uncomfortable.
If
And if there are barriers to someone acknowledging those things, or even just seeking support, then the part of the priority is, well, what are those barriers and how can we change them? We see that we're talking, we've talked a lot about mothers here, but I think this is a significant issue for fathers.
Yeah.
And because the masculinity is just so wrapped up in this, about how can you be a man, quote unquote, that sort of stereotypical Western perspective of what manliness or masculinity is, and go to therapy.
Yeah.
Because that, of course, I believe you firmly can, and I think there's different forms of masculinity, and masculinity can be performed, and you can be masculine in different ways.
Yeah. Yeah.
But for people who maybe haven't, delved into that work as much as I have, then that can be really scary. And I think this is also one of the reasons why we see fathers being more likely to deny the existence of ADHD and autism in their children. So I saw it all the time, and we still see this, and the research shows this as well, that dads are more likely to say, "Oh well, boys will be boys.
Oh,
Actually, you've diagnosed with ADHD, but I think it's a load of rubbish. I don't believe in that."
yeah.
And one of the reasons the exacerbating reasons, one of the reasons why I think that's happening, and I'd love to be corrected on this, but I'm confident with this one, is that if you've got a dad who sees a lot of himself in his son or his daughter or his child, and the child's been diagnosed as neurodivergent, which we do, it's the most hereditable condition in psychiatry, the dad has two options. Option one if my son has ADHD or is autistic, or my daughter has ADHD autistic, and they're like me, does that mean I'm ADHD autistic? And now you have to reflect, am I disabled? Am I different? Am I divergent? No, I don't feel those things because being disabled, that's not masculine. That's not part of my identity. So one option is to accept that, look in the mirror, and it might be you as well. You might be the neurodivergent link here. You might be the neurodivergent parent. Most of the time, there's one of you.
Mm-hmm.
Or the other alternative is to reject the entire premise. ADHD doesn't exist. Autism doesn't exist. I'm not disabled. I don't have ADHD. I'm not different, and neither is my child. And that second option is so much more psychologically comfortable because it doesn't require us to not only look in the mirror, but to reflect on what does it now mean to be the father of a, to use medical language, disabled child.
Yes.
What does that now mean for you? And that can be really distressing. I am seeing a shift here. I am seeing more dads be involved. I am seeing, and I think my sample size is probably biased because I am a father. I talk about ADHD all the time. I talk about my own neurodivergence. So I get a lot of dads tell me about theirs.
Mm.
I get a lot of dads tell me about how their daughter got diagnosed and now they're thinking they have it as well.
Yeah.
And I had some people coming and doing some building work in my house. And one of them was like, oh, yeah. And he started just telling us about his ADHD and his child's ADHD. It was really nice. And the people who he was working with said, yeah, I didn't know that. He'd worked with them for 10 years.
Yeah.
The first time he talked about it in front of them was to me. So to challenge this, we have to normalize. We have to normalize in these conversations about, you know what, you can be masculine and have ADHD.
Yeah.
You can be an emotional mom and to use the language, an overly emotional mom, a dysregulated mom, and also have an ADHD child. Like you can be trying your hardest, but still need to work on yourself to be able to hit that next level of outcome. And these uncomfortable truths can only be challenged by really open and nuanced conversation.
Mm. Really, really well said, Dr. Tom. Thank you so much for this. It's just so illuminating, and you're just like hitting the nail on the head with all of these topics. And I wish we had hours to chat. I could chat to you all day, I'm sure. But I think that one of the last questions really that I want to ask you is if there's somebody listening right now and they are traversing this experience for either themselves as a parent, their child, and or both, maybe both, and they're kind of on the waiting list. I mean, we haven't even touched the NHS, like the right to choose track as well. There's just so much out there for these folks. What do you say to them?
Have hope, because as much as we talk about the challenges, the difficulties, the unfairness, the unjust experiences, and they do get a lot of the airtime on all of the discussion here. I've also worked and met thousands of people who have had such positive journeys that were difficult and now they're in much better places.
Mhm.
I've worked with people who, there's someone who I'm making a documentary with at the moment about ADHD and who completely changed his entire life for the better, much healthier in every way after his diagnosis. It was a long wait, and it was hard, and then everything got better. I've worked with families where the child's gotten a diagnosis and then a few years later dad did and then mom did, and now they've gone from this really fractious, difficult experience to this happy, we are a neurodivergent family and we do things differently here, because they started changing the metric and the measuring stick of how they would be performing family, what they were going to do as a family. Our family doesn't work like other families, so we're going to be different and we're going to do things differently. I was speaking to someone very recently whose kid has a climbing wall in his bedroom, like next to his bed. So he climbs on his wall, and he's like, and the dad's like, "That's just how we do it." Like, it's to have hope that things can get better, because things are pretty grim in some areas of neurodivergence right now. But there's also some wonderful work happening. There are also people who deeply care about this, who've been fighting. You know, I've been fighting for this for 12 years. we've been fighting to make things better, and we're seeing improvement. Things are better than they were in some areas 10, 12 years ago. Some things are worse. Some schools are incredible. Some schools are really neuro-inclusive. Some are still in the 1980s in terms of their strategies. But there's more of the good ones coming up every day. And there's more people getting trained. And there's more people talking about this. And it's going to continue to be rocky. There's gonna be, as we see with some of the political discourse at this point, which is absolutely abhorrent. I don't wanna get into it too much because I'd go on a rant, but I've just wrote a blog post recently about some of the political statements being made about neurodivergent people. But these things are cyclical. They do change. They do adapt. The Overton window moves, which is like what is acceptable and what is normal. Our perception of this changes. It wasn't that long ago that women couldn't vote. It wasn't that long ago that children were down the mines. Now, I'm not saying wait 80 years for these changes because it's not that long, but things every year feels like every month, every day, every week, maybe a year feels like a long, long, long time. But a lot changes in 5 years. A lot changes in 10 years. AuDHD as a diagnosis couldn't even be given until 2013. Like ADHD and autism couldn't literally be co-occurring as diagnoses until 2013. For only 12 years, we've been able to accept that someone can be ADHD and autistic. That's only 12 years. What's this going to look like in 12 more? All we can try and do is just minimize the damage and maximize the benefit at this point. And just, yeah, keep fighting, keep changing the narrative, changing the story about what does neurodivergence mean to you and your family. Not what does it mean 10 Downing Street? What does it mean for you?
I love that. I love that, Dr. Tom. What does it mean for you? And that there is hope that change will happen.
Yeah,
Beautifully, beautifully.
totally. I see so many people's lives being better, both post-diagnosis and if not diagnosis, just post-learning about it, post-reading and consuming and just making changes. Sometimes it's as simple as that. And that's what makes life worth living. Because it's never going to be perfect.
Never going to be perfect. We're never going to be perfect. It's not going to be perfect. So thank you ever so much, Dr. Tom Nicholson, for coming on Tea with the Experts and Dr. Leah Merle to talk about everything neurodivergence as well as what is AuDHD. Thank you, Dr. Tom. I wish you the best.
Thank you very much. And if anyone wants to continue this conversation, please reach out at tom@drtomnicholson.com or follow us on LinkedIn or social media. And I deliver training on all aspects of neurodivergence and try to be as helpful as I can.